Thank you. Good afternoon, at least here in the US. So I'm just going to give some highlights from some talks at CROI that reviewed a little bit of data from vaccines and also some new information about the pathophysiology of COVID-19. So some of the data that came out was about the first immune responses that we get following SARS-CoV-2 infection and what that might portend for us in terms of our clinical course. This was a presentation by Dr. Iwasaki from Yale University. So this was a bunch of descriptive data that kind of showed, what does it look like in the heat of the moment of early COVID infection? And those of us in clinical practice are used to seeing that there is a big drop in your T cell count. So you have this absolute lymphopenia that occurs. And that's reflected here in this graph. And here they're looking at a whole bunch of cell counts as well as different cytokine levels sorted by a kind of placebo group, which are the healthcare workers, and then moderate and severe disease. And there's low T cells for kind of all cases. But what you really see for severe disease is that you have very high levels of IL-6, which we know clinically, as well as other cytokines. And they really track with the severity of disease. So they also took a look at whether or not these elevated levels of interferons and cytokines also correlated with virologic control or inversely. And they found that there was an association between higher levels of cytokines and higher levels of virus in nasopharyngeal samples. So, squinting at these figures, the coefficient of correlation is not very high, these little R values, but I think what they're trying to show here is kind of tell a story that the higher levels of cytokines inflammatory response that patients have is associated with worsened disease and also higher amounts of virus. So that begs the question, well, those things are tracking together, but are they pathophysiologically linked? And so they tried to address this question by looking at the patients that were discharged versus the patients that died, and then going back and looking at their cytokine levels at the time of their early presentation. And what they found here is that it certainly wasn't protective to have higher cytokine levels. So if you take a look at like IL-6, for example, those levels seem to predict that those patients would go on to die. But, I don't know exactly the full set, and maybe they haven't either in terms of all the confounding variables. But again, it's kind of showing you a picture that this inflammatory response, may be associated with worsened outcomes. One of the rationales for why that could be the case is that maybe there's something going on where really severe disease is correlated with autoimmunity, particularly autoantibodies against some of these important inflammatory molecules. So here they looked at the diversity of antibody responses by severity of disease and saw, increased diversity of autoantibodies for very severe disease. And then they showed some additional slides, which I won't go into here, that, it looks like the more antibodies you have against your cytokines, the worse your virologic outcomes. So they came together and kind of put all this data together to say that the interferon response that people have in the setting of infection is really, what really matters is the timing. So they kind of pointed out with young patients that had low viral exposure and they had an early robust burst of interferon, for example, then they had a drop in their viral load and they had mild disease. And in contrast, when you had these older adults that had high viral exposure, and they had a delayed interferon response that just went up and up and up. Those were cases of severe disease where you had viral persistence and inflammation. And that there may be additional data from cohorts of people that have these neutralizing antibodies to the interferons that you kind of get the same pattern. So one of the topics that really interests me as a vaccine scientist is durability of host immune responses in natural infection, both in our humoral and our cellular compartments. And there was some data on this topic. This presentation from Dr. Finzi in Canada looked at longitudinal humoral responses. This is what's shown here to the receptor binding domain, which is that domain that's on the top of the spike protein. We've seen some of this data before in other publications that are out there, just looking at the kinetics, but this is a little bit longer follow-up than we usually see, so 250 days. And there, the patterns are kind of what you would expect in a viral infection. The IgM levels are high in the beginning and fall off quickly, as do some of the IgA, but IgG persists for much longer. And what they found is kind of hard to see in the bottom right corner is that after 31 weeks of infection, 100% of the participants were still seropositive against RBD. They also looked at neutralizing titers and also ADCC. So ADCC is antibody-dependent cellular cytotoxicity. So like, what is that? That's non-neutralizing antibody responses. So antibodies that actually coordinate cellular, almost like T-cell activity. So, it may be concerning, but I'll get back to this. You see this rapid drop off of neutralization, but don't worry, those will come back. All in all, what you can see in this big figure that they show is that a lot of the immune responses, of course, they come down over time. But what does not come down over time and what persists, and actually I'll show you goes up, is our memory. So our memory B cell responses continue to be robust over time. So one of the things you want to know when you have an immune response is is it boostable, meaning do you have recall? So yes, our antibody titers can come down, but what really matters is if when we're exposed to an antigen again, do we have a robust immune response that quickly gets on the case? And this seems to be what's happening. So in the central figure is the neutralization titers that are quite low. If you looked at that by yourself on its own, you'd be concerned. But then after a single dose of Pfizer, the mRNA-based vaccine, which you can consider an antigen exposure, there's a very rapid recall response. And that was true across all these compartments of the humoral immune response. So moving on to a presentation by Dr. McElrath at the Fred Hutchinson Cancer Research Center in Seattle. She showed a lot of data for the T-cell arm that was very consistent with this. So here she was showing, again, actually the B cells, that memory IgG positive B cells actually didn't go down. They actually continued to rise in COVID-19 participants over time. If you just looked at IgM, you'd see that IgM drop and the IgA drop, but the IgG stayed nice and high. So then for our T cells, CD4 positive T cells, well, they didn't have a very particular immunodominant antigen that they all went for. You can see on the right all the different antigens that were tested, diffuse across all the different proteins. But what was important to see is that the half-life of these T cells was long. It's 207 days. So these CD4 T cells are hanging out for a while. I'm not showing it here, but she also showed that they not only are they there in terms of just detecting them, but they also maintain a lot of function. This was true for CD8 positive T cells as well. The CD8 positive T cells do have an immunodominant pattern where they're focused on the nuclear capsid protein, which is shown here as the N set of peptides. So they seem to focus a lot on that, which makes some sense, right? Because that's a real intracellular protein in the setting of intracellular infection. But most promisingly, the CD8 T cell responses decayed, but they don't decay very quickly. And they're a very good recall. So previously I showed you the data from the earlier presentation showing that IgM responses really went up from antibodies. Well, here you also have the memory B cells themselves really robustly proliferating essentially in the setting of an exposure to new antigen, in this case, vaccine. So I know that Dr. Kritzkis later is going to talk a lot more about the variants and also about some of the cross-neutralization we may or may not see following vaccination. This is just one slide that showed some of the data they were showing for natural infection in this regard. Here they had sera from what they call wave 1, which is kind of the earlier strain. Some people call it Washington or Wuhan strains. And then seeing if they can neutralize the B117 strain. And they were able. These antibodies were very effective at neutralizing, maybe a little bit decreased titers, but still pretty effective. And they had additional data here that I'm not going to show, showing that the reverse was also true. So a small cohort of people who'd been infected with B117, their antibodies also were able to neutralize Wuhan strains. So here's some thoughts about the vaccine. Vaccine data, it comes out so quick. I think it's too quick even for a conference. There a lot of the talks that came out on the vaccines were not so much new data as more perspectives on how to interpret the data. So this was a talk by Dr. Nuzzo at the University of Maryland, and she's one of the principal investigators in the US of the COVID trial prevention network. So she put this slide up there, which kind of represents like all the parameters of the current vaccines that are out there with good data to look at and compare across them. There's always new data, and they're always, tables like this are always out of date. So of course we have brand new data for AstraZeneca, for example. But one of the things I liked that she presented was she put this table together, a framework for interpreting and comparing estimates of efficacy. So we see these reports come out, we see 60% efficacy, we see 95% efficacy. How can we, is it always apples to apples, or sometimes is it apples to oranges? So how can we compare these numbers? So what she gave, I think, are some good tools to think about and how to compare. And one of them, you can see them here in this table, but the most important ones are things like the study population. So if you have a study that's done in mostly older age individuals with chronic conditions, they're more likely to develop severe disease. And so you may be able to detect efficacy against severe disease better than in some other trials. But at the same time, you might have lower immune responses because of age, and that may also affect your efficacy. Something that we've seen a lot, I think is probably going to turn out to be a big deal is, what is the circulating strain at the time that you test a vaccine? So if your vaccines are perfectly matched to the circulating strain, then you're likely to get a better response than if there's a mismatch. Also, interestingly, the force of infection, what does that mean, the force? The force of infection means how brisk is this pandemic at the time that you're testing this vaccine? A person can be exposed multiple times if the infection is so bad in their area. So if you have a very high force of infection, it can actually overwhelm vaccine immunity and decrease your efficacy estimates. Not all of the studies measure efficacy the same way or measure or define severity the same way. And then the timing of the vaccine assessment. A lot of these studies have been done where vaccines are being tested in the setting of such active replication and transmission that they're getting a lot of endpoints, just a few weeks from vaccination. Sometimes that's not enough. Sometimes vaccine responses need to mature. So if you are capturing all your cases early versus late, that may actually affect your efficacy as well. So I think I really enjoyed this table. I feel like it really gives a lot of good tools to interpreting the studies. So finally, I just will end on a more perspective presentation that was done by CEPI, which is an organization that works on epidemic preparedness and also works on COVAX, which is a model for sharing vaccine and more equitable global allocation and distribution of vaccines. And some of the lessons that they had wanted to share is that COVID-19 provides an opportunity to think about how we systematically reduce the risk of naturally occurring threats. And that these trends are converging in a way that could make us better prepared if we look quickly enough at what we're doing and learn from it. So that means harnessing the political will to invest in health security, to take advantage of these revolutions in vaccinology, to take advantage of the fact that now everybody cares about pandemics, and to use that opportunity to tackle these things collaboratively in the future. So in particular, advocating for a global end-to-end research and development system and financing model for preparedness and response. Thank you very much, and I'll end there.